Hello, I'm Judy Heidebrink, a neurologist with the Michigan Alzheimer's Disease Research Center. Welcome to this presentation on the pharmacologic treatment of dementia, part 1 of 2. I'll start with my disclosures. I received research funding from AZI and Cognition Therapeutics. The goals of this presentation are to review the FDA-approved medications used for the treatment of the cognitive impairment that occurs with Alzheimer's disease and other dementias. In part 1, I'll be focusing on the neurotransmitter-based therapies, and in a separate part 2 presentation, I'll talk more specifically about the anti-amyloid therapies, the immunotherapies for Alzheimer's disease. What I'll cover is how do these medications work, what are their benefits and side effects, and when are they typically used. So in the clinic, we might encounter an individual such as the woman described here, who's in her 70s. She's been experiencing a 2-year history of gradually progressive cognitive decline with early prominent memory loss. It's starting to impact her daily activities. She needs help now with her medications, managing her calendar, keeping track of her finances. And after an appropriate evaluation, she's diagnosed with mild Alzheimer's disease dementia. And she or her family might ask, are there any medications that might help her thinking? This slide shows the neurotransmitter-based medications for Alzheimer's disease dementia. And there are 2 types of these medications. First, there are medications that act on the cholinergic pathway, medications considered cholinesterase inhibitors. And secondly, there is a medication that works on the glutamate pathway, a glutamate antagonist. The last medication on the table is simply a combination of one of the cholinesterase inhibitors and the glutamate antagonist. And as you can see in the right-hand side of the table, these are indicated for different levels of dementia severity with Alzheimer's disease dementia. So how do these medications work? Let's start with the cholinergic therapies. In Alzheimer's disease, there is a selective loss of the cholinergic pathways in neurons, some of which are shown on the left image on this slide. The right image is a magnified view of a cholinergic synapse. Acetylcholine, which is depicted by the small green bubbles, is synthesized and released into the synapse where it interacts with a postsynaptic receptor on the adjacent neuron. The acetylcholine is then broken down by acetylcholine esterase before being taken back up into the presynaptic terminal. So when there is loss of those cholinergic neurons, there's a loss of cholinergic activity at the synapses, but compounds that can block the breakdown of acetylcholine by blocking the acetylcholine esterase will allow the remaining acetylcholine to hang around longer and compensate for that cholinergic deficit. That's the mechanism of action of the cholinesterase inhibitors. What is the expected benefit of a cholinesterase inhibitor? This was the question studied in several trials of cholinesterase inhibitors, typically focusing on individuals with mild to moderate dementia due to Alzheimer's disease, but some later studies also included individuals with severe dementia due to Alzheimer's disease. In the trials with individuals with mild to moderate level of severity, they used an outcome measure called the Alzheimer's Disease Assessment Scale for Cognition. It's enhanced in the type of tasks that are often affected by Alzheimer's disease, so there are many tasks involving memory and language. Altogether, it's worth 70 points, and the errors are scored. So a higher score means worse performance. And in someone with mild to moderate Alzheimer's disease dementia, without any treatment, they typically have a rise in their ADAS-Cog score of around 7 points per year. So this is a research-based tool. It's a little different than what might have been used in the clinic at the time that these studies were being done, which is the mini mental state examination shown on the left, which doesn't have as much emphasis on the things that can change over a relatively short period of time, the way the ADAS-Cog does. So what happens to someone's ADAS-Cog score if they receive a cholinesterase inhibitor? So this slide depicts the results of the pivotal phase 3 trials that led to the FDA approval of the cholinesterase inhibitors that are currently in use. The graphs on each slide are inverted so that fewer errors on the ADAS-Cog represents a higher point on the graph. So better performance is higher up on the graph, which is reflecting a lower ADAS-Cog score or fewer errors. So if you track the change in ADAS-Cog score over time in individuals either receiving the active therapy versus the placebo, in all cases at the end of trials of roughly 6-month duration, there's about a 4-point difference between the individuals receiving the active therapy versus the individuals receiving a placebo. So in a sense, the medications are helping maintain someone's cognition or delaying that decline by roughly 6 months, about a half year's worth of progression, by having a 4-point better score on the ADAS-Cog. Now, unfortunately, these medications can't maintain someone's cognition at the same level indefinitely. There is ultimately a decline even with ongoing treatment, but those individuals are still testing at a higher level than individuals who never received a cholinesterase inhibitor. So it's delaying or offsetting that decline by somewhere around 6 to 12 months. In addition to the cognitive benefit of cholinergic therapy, there can also be benefits in other outcomes used in clinical trials, including behavioral outcomes. For example, there may be less apathy when a cholinesterase inhibitor is used. There is better maintenance of activities of daily living. And looking at overall ratings of someone's general clinical well-being, in individuals receiving a cholinergic therapy, typically after 6 months, they're felt to be relatively stable compared to individuals who don't receive the therapy, where they are felt to have declined a bit. Measures of quality of life also favor the use of a cholinesterase inhibitor, as do some economic models when taking into account particularly informal costs of caregiving that may be offset by someone's higher level of independence with this type of therapy. Now let's go back to our hypothetical patient who has been on a cholinesterase inhibitor for several years. She did experience an initial stability followed by gradual decline, which would not be unexpected with this type of therapy. She's now reached a moderate dementia stage due to Alzheimer's disease. What other treatments might be available to her now? Again, referring back to the FDA-approved medications that work on altered neurotransmitters in Alzheimer's dementia, when individuals are at the moderate or severe stage of Alzheimer's disease, they may be candidates for the glutamatergic-based therapy known as memantine. How does this drug work? This is a depiction of a glutamatergic synapse and how it is disrupted by Alzheimer's disease pathology and improved with use of a non-competitive NMDA glutamate antagonist known as memantine. The top left shows the changes due to Alzheimer's disease in which there's an excess amount of tonic activity at the glutamatergic synapse. So there's too much background noise that it can make it hard to tease out when a surge of glutamate comes through as part of a learning or memory process. On the top right, you can see memantine, shown as the blue circle, is now blocking the glutamatergic synapse and dampening down that background noise. However, in the bottom left, when a glutamatergic signal comes through, memantine will then move out of the way so that in the bottom right, you can see the glutamatergic signal can be heard above the background noise. What's the clinical effect of taking memantine? Slide shows the key results of 2 trials of memantine in individuals with moderate to severe Alzheimer's disease. On the left, memantine was compared to placebo. Individuals were not receiving any other therapy. On the right, individuals were already taking the cholinesterase inhibitor donepezil and were given either memantine in addition or a placebo. And you can see in both cases there is an offset in terms of the decline on this cognitive measure called the severe impairment battery in individuals who receive the memantine compared to placebo. So both groups do eventually decline over time, and their slope of decline looks similar, but that decline is occurring later and they're functioning at a higher level if they receive the memantine versus the placebo. And on the right, you can see that's the case even when they're already on donepezil, further supporting that memantine is working on a different pathway so that the two medications could be used in combination in individuals with moderate or severe dementia due to Alzheimer's disease. So overall, when it comes to the neurotransmitter-based therapies in Alzheimer's disease, they delay the cognitive and or functional decline by somewhere around 6 to 12 months. And even when there is decline, individuals taking these therapies are still functioning and testing at a higher level than individuals who never receive the therapy. There may be a behavioral response and a reduction in caregiving time as individuals are maintaining a higher level of independence. What are the side effects of these neurotransmitter-based therapy? They are different for each type of therapy. For the cholinesterase inhibitors, although we're enhancing acetylcholine in the brain, we're also inadvertently enhancing it in other parts of the body. There is a lot of acetylcholine in the intestinal tract, so gastrointestinal side effects are by far the most common and include things like nausea, upset stomach, or diarrhea. We also release acetylcholine when we dream, so dreams can be enhanced with use of these medications. And there's acetylcholine in the junction between nerves and muscles, so in some cases that can lead to muscle cramps or heart muscle side effects, including a slower heart rate or rarely other heart rhythm changes. Memantine has a different set of side effects. In contrast to the diarrhea that can occur with the cholinesterase inhibitors, memantine can lead to constipation, so use of the two together may actually neutralize one another in terms of GI side effects and be better tolerated than either one alone. There can be headaches associated with memantine, although interestingly, memantine is also sometimes used as a treatment for headaches in other individuals. And there can be some more nonspecific types of side effects like lightheadedness, or interestingly, transient confusion was observed in the first several weeks of treatment, which may be again somewhat accommodating to those glutamatergic changes, since we don't want too much, but we also don't want too little glutamate acting in the brain. How about using these neurotransmitter-based therapies in other dementias? The other main use of the cholinesterase inhibitors is in the Lewy body dementias. It turns out that in some of the original trials of the cholinesterase inhibitors in individuals clinically diagnosed with Alzheimer's disease, when some of those individuals passed away and donated their brains to science, some of them had evidence of Lewy body pathology, and interestingly, those individuals often had even a more robust response to the cholinergic therapy. From a clinical standpoint, we'll see that they can be more sensitive to starting a cholinesterase inhibitor in terms of experiencing an improvement or experiencing a decline when a cholinesterase inhibitor is stopped. And that makes sense since the cholinergic deficit in Lewy body dementias may be greater at a given level of severity than in Alzheimer's disease. Based on studies in individuals with Parkinson's disease dementia, or PDD, rivastigmine was approved by the FDA for its use. There have been some smaller studies of memantine in either dementia with Lewy bodies or Parkinson's disease dementia, so the Lewy body dementias, and the results here have been more mixed. This slide shows the benefit of rivastigmine when given to individuals with Parkinson's disease dementia. Here the ADAS-Cog was used, similar to the outcome in the Alzheimer's disease dementia trials, and very similarly, a 3 to 4 point difference on the ADAS-Cog measures at the end of roughly 6 months of therapy. And again, this supports the clinical use of cholinesterase inhibitors in the Lewy body dementias. And in this interesting study, they actually had pre-specified times to start a therapy and stop a therapy in individuals with Lewy body dementia. These individuals could either have Parkinson's disease with Lewy body dementia or dementia with Lewy body. So they could have started with Parkinson's disease first, or they could have started with the cognitive syndrome. And they were given a cholinesterase inhibitor for a period of time, stopped at a preset time, and then restarted to see if there were changes in either cognition or on certain behaviors, which were measured by something called the neuropsychiatric inventory. The left-hand slide shows the cognitive scores on the mini-mental state examination. You can see there's a bump up with the initial 20 weeks of therapy, followed by a drop as they were taken off the medication, and then an improvement again once they were resumed on the cholinergic therapy. On the right-hand portion of the slide are the measures of behavioral symptoms. A higher score would mean more disruptive behaviors or concerning behaviors. So the goal is to have a lower score. And you can see the average NPI scores were falling during the first 20 weeks of therapy, rose fairly dramatically when the medication was withdrawn, and then came back down again when the therapy was resumed. Again, showing that sensitivity to starting and stopping a cholinesterase inhibitor in individuals with Lewy body dementia. What about other dementias? Are the Alzheimer's-based drugs, the neurochemical-based drugs, helpful in some of the other types of dementia? For vascular dementia, a small cognitive benefit has been demonstrated in clinical trials, but pure vascular dementia is rare, and it might be that the benefit was driven by mixed pathologies. In general, if someone is felt to have Alzheimer's disease and vascular dementia, use of an Alzheimer's disease therapy would be appropriate for that individual with a mixed dementia. In contrast, individuals with frontotemporal dementia, particularly the behavioral subtype, seem to do more poorly when given a cholinesterase inhibitor with greater behavioral symptomatology. And in a study of memantine, individuals with a clinical diagnosis of frontotemporal dementia had greater decline when they received memantine versus the placebo. So generally, we do not use either the cholinesterase inhibitors or memantine if we think someone has a frontotemporal dementia. The one exception was a small study when individuals had language symptoms felt to represent underlying frontotemporal dementia. A cholinesterase inhibitor was felt to be potentially beneficial, but it is also possible that these individuals actually had Alzheimer's disease as the underlying pathology rather than a true frontotemporal dementia. So in summary, the cholinesterase inhibitors are approved therapies for Alzheimer's disease dementia across severities, and also approved therapies for individuals with Parkinson's disease dementia that is mild or moderate in severity, but are often used in dementia with Lewy bodies as well. Memantine is an approved therapy for moderate to severe Alzheimer's disease dementia. And overall, these neurochemical-based therapies are considered symptomatic therapies for Alzheimer's disease dementia, as shown on this slide. So if the natural course of cognitive decline is the red line, the cholinesterase inhibitors and memantine may delay that decline or offset that decline, but when that decline occurs, it's at a similar rate, just offset by 6 to 12 months compared to the natural course. So this is a symptomatic therapy. It's not changing the slope of the line, it's just delaying or offsetting it. And it's also not targeting the underlying pathology of Alzheimer's, for example, the accumulation of the plaques and tangles. Ideally, we'd like to have disease-modifying therapies, ones that attack the underlying pathology and change the rate of decline. I'll be talking about disease-modifying therapies for Alzheimer's disease in part 2 of this presentation, and hopefully we'll eventually get to the case where it's not just modifying, i.e. slowing that decline by the rate, but actually reversing it to a cure. Not there yet, but stay tuned for part 2 to hear more about disease-modifying therapies.